All right, let's get started. So welcome to the June 2025 Nursing Grand Rounds. Wow, almost July. All right, guys, attention, please. Okay. So our topic today is difficult intravenous access, and we have two fabulous presenters with us today. We have Julia Steiner with the Vascular Access Team and Perla Roberts, one of our clinical professional development educators. Just going to go over some housekeeping items first. Hold on one second, I'm not going. All right. So please hold all questions until the end of the presentation. If you're on Teams, please type it into the chat and we will address the questions. We ask the audience, please silence their phones at this time, and anyone on Teams, please keep yourselves on mute. All in-person attendees will receive a clinical ladder certificate at the end of the presentation. All attendees on Teams, we will email you a survey to complete by the end of this week to your work email to receive clinical ladder points. Clinical ladder points will only be awarded to Teams attendees that have logged on within the first 10 minutes, camera on the entire meeting, and log off at the end. And now, without further ado, I'm going to hand it off to Julia Steiner.
Hi, everyone. Okay, so the aim of the presentation is to spotlight clinical implications related to difficult intravenous access among our inpatient population. DIVA refers to a situation where a patient's veins are challenging to access for IV procedures. This can result in multiple failed attempts at catheter insertion or need for special technique. So we're going to discuss effective strategies in challenging situations and highlight the best practice to date. I'm sure we've all heard this stated before by one of our patients or one of our fellow colleagues has experienced this. I'm sure you all look forward to hearing this with your change of shift admissions. Okay, so I just want you to read this and just think of a number in your head. So what % of hospitalized patients receive IV therapy through a peripheral IV? And, okay, pretty good, pretty good. Okay, so based on our research, we concluded that more than 80 to 90% of hospitalized patients receive IV therapy through a peripheral IV. So some of our objectives. Although there is no universal definition of difficult intravenous access, we have composed our own definition based on the most recent data and statistically significant research to date. Nurses are the forefront in providing IV therapy, so we really want you to be able to identify risk factors and discuss strategies to help manage difficult intravenous access patients. We do also want to identify alternative access to PIV placements. Nurses can also assess what IV access would benefit the patient the most and what would align with the plan of care. If you have a patient with a planned surgery who either is on long-term antibiotics or has no PO access, that's going to be different than a patient who has a planned discharge in one day. It's also important to keep an open mind and be flexible about a patient's IV access and what is most comfortable for you as the nurse. This is just some background. Nearly 200 million PIVs are placed annually in the US, and approximately 800,000 fail on the first attempt. DIVA significantly contributes to multiple PIV failed attempts. Establishing peripheral intravenous access is clearly challenging, particularly in patients with smaller collapsed veins. Maintaining vascular access through treatment can be difficult due to complications such as phlebitis, infiltration, and infection. While the majority of attempts are successful, a significant number of patients present with difficult intravenous access, and this can lead to multiple sticks and increasing patient discomfort and anxiety. Okay, this is a little clinical scenario for you. So, Miss Carter, 67 years old, she has a history of long-standing peripheral vascular disease, multiple previous hospitalizations, and current medications include IV furosemide, insulin, and prophylactic antibiotics. So this is a little question for you. So RN Phoebe has attempted obtaining IV access 2 times for this patient and is now asking you to try to stick the patient one more time. The IV medications for the patient are past due, and Phoebe is overwhelmed with her admission, and you want to help her. What is the best course of action? Yeah. Okay. So you do want to escalate to the provider. Early recognition of DIVA is crucial, and advocating for alternative access is key. Just going back, you could hypothetically hide in the break room, but most of our break rooms are the size of a closet, so it's not going to help much. Okay. Okay, so some venous access essentials. So it should be secure and reliable. Saying that 22 in the thumb, that's leaking and kind of working, kind of hurts the patient, are terms we really want to step away from. Delayed or missed medication doses are the most direct consequence in the patient not receiving their prescribed medications. Treatment may become ineffective or less effective when the patient does not receive necessary IV medications, and that can potentially worsen their condition and prolong their hospital stay and lead to greater hospital costs. Many diagnostic tests and medical procedures require IV access for contrast agents or sedation, and delays in obtaining access can impede these processes. Also, of course, to note, not having reliable access can lead to life-threatening situations. Okay, so these are just some uses for peripheral IV catheters. They're indicated for short-term IV medications and solutions that are compatible for peripheral use. And you want to always keep in mind the pH and the osmolality of the medications you're infusing in the PIVs. So for example, medications that we give commonly, vancomycin and Zosyn. So vancomycin has a pH around 2.5 to like 4.5. And if you think like the lemon juice you put in your water or the vinegar you put on your salad has a similar pH. Now imagine infusing that in your veins and how caustic that is. Zosyn has a pH around 5.5 to 6.8, which is much more compatible for a PIV. So for vancomycin, we really recommend a midline or something like a PICC line. The acidic nature of vancomycin solutions means they could ideally be fused through a catheter tip located in a large vein. There's a risk for phlebitis when you infuse it through a peripheral IV. And it's considered a vesicant medication, so meaning it can cause tissue damage if it leaks outside of the vein. So based on the data that Perla and I have researched and what's most up to date, our definition of difficult intravenous access is 2 unsuccessful attempts, a patient with a known history of poor IV access, if they stated I'm a very hard stick, they need the ultrasound usually, or non-palpable veins or visible veins. So I know based on this probably sounds like most, if not all of your patients. Some of the most commonly chronic conditions hypothesized as risk factors are obesity, diabetes, IV drug abuse, chemotherapy, and dialysis. Regarding the influence of chronic health conditions, it is hypothesized that a higher visitation of the health system would generate a higher use of vascular lines, which can lead to progressive fibrosis. The use of vesicant IV infusions during the hospital stay is another common factor potentially affecting this population, which could especially be present in patients receiving IV chemotherapy. And then two mechanisms, multiple venous punctures and IV vesicants, are present in IV drug users, which is going to then lead to progressive microvascular degradation. So this is a nice little graph here where you can see all the risk factors. I'm sure most of your patients have at least one of these, if not multiple factors, including peripheral edema, obesity, chemotherapy, hypovolemia, IV drug abuse, older age, ethnicity, female gender are associated with greater incidence. And then in the case of diabetes, microvascular alterations secondary to hyperglycemia could be an added mechanism. Small peripheral veins with a diameter and visibility and palpability can vary between individuals. And then it's also important to keep in mind that these are general trends, and there's, of course, individual factors that play a part. So I know everyone's favorite, some research. This was published in the Journal of Vascular Access by Ball and colleagues in 2001. This is a systematic, 2021. This is a systematic literature review was designed to identify clinical cost and quality of life publications in patients requiring the insertion of a PIV in any setting, including studies on ultrasound-guided and or guide wire. The studies included no specific intervention. 43 publications provided a definition of difficult intravenous access in adult patients, pediatrics, or missed populations, and basically composed 6 general themes. So theme 1 was a failed attempt at PIV access using traditional technique, which includes vein visualization, palpation, and landmarking. Theme 2 is based on physical examination findings, for example, no visible or palpable veins. Theme 3, personal history of difficult intravenous access. Theme 4 is a history of end-stage renal disease, IV drug abuse, or other chronic medical conditions. Theme 5 were those where the operator was required to place the IV line. And then theme 6 is the use of method of a rescue vascular access device to establish IV line. So these are, again, just some numbers for you. So 30% of PIVs are considered difficult, and 59% of difficult intravenous accents occur in complex diagnoses and chronic illnesses. It's more prevalent in patients with underlying risk factors. However, acute changes affecting hemodynamic status can potentiate difficult intravenous access. Okay. So just some patient experience. They have a mistrust with the health system. You know, they'll be refusing medications, requiring like a lot of IV sticks just leads to a general mistrust in the nurses, fear, anger. Difficult intravenous access patients' experiences are unique, and they are often judged or ostracized in response, and they become defensive and resistant to help or to vascular access care, especially for phlebotomy or a PIV placement. So again, just reiterating, multiple failed attempts, patients experience pain and suffering, there's a delay in treatment, refusal for PIV medication and prolonged hospitalized stay, and also a needle phobia. So hospital cost. So this was published in the journal Research in Nursing by Gallant and colleagues in 2023. This was a targeted literature review, obtained model parameter data, and included published literature for terms including relative variations of difficult venous access, such as burden, costs, or elicited from expert clinical opinion. Results included number of insertion attempts, number of patients requiring escalation, catheter failures due to complications, healthcare professional time, and total costs. The model considers 64,000 individuals presenting into the emergency room annually, of which 75% require a PIV line. And these 22% are estimated to have difficult venous access. So the total cost burden of difficult venous access is estimated to be a little under 900,000 per year, which is roughly $84.29 per patient with difficult venous access. Key cost drivers include population size treated in the emergency department, the proportion of midlines placed by a specialized IV nurse, and the percentage of patients with difficult venous access. So approximately 30% of PIV cost is due to material waste related to unsuccessful insertion attempts. So when you get your flush, the luer lock, multiple different lines, let's say you open the package for a 22 gauge, for a 20 gauge, open the flush up, and then you can't get the IV and you throw all of that out. That's all adding to cost and also your clinician time on, what you spent on that given patient. And sometimes we have nurses like calling us and telling us, we stuck the patient 8 times. Just think how much material and time that is, and not just you as one nurse, but like if you're, asking your colleagues to help you, all really adds up. Okay. So this is just what we want to just talk about, like how you can reduce your failed attempts and the different accesses you can, the hospital provides. And then we're also going to strive for excellence in care delivery. We're going to talk about different technologies that our hospital offers for patients with different types of lines. And Perla's just going to come and talk now a little bit about the role of technology, including like ultrasound guided IVs.
Hi, everyone. Picking up from where Julia left off. So here at North Shore University Hospital, we have at least 3 different categories of technology, or simplest being thermal therapy. And thermal therapy increases visibility and palpation. Our phototherapy, which is our infrared imaging devices, emits light waves, highlighting veins, and ultrasonography uses sound waves to identify veins. So big term, thermotherapy is our hot pack. It's applying heat to the skin surface. When heat is applied, blood supply comes closer to the surface, bringing nitric oxide that affects vascular tone, dilating the veins, making them bigger and palpable. So that's what it is. Even if it seems simple, it is effective if you apply it for at least 5 to 10 minutes. And just be mindful of the patient's skin integrity, because for fragile skin, there's a potential for burns. Often, I remember as a vascular access nurse on the night shift, I'd be called by nurses to place an IV. And I'll say to them, did you try? Yes, 10 of us try. How many people try? Even the provider try. And I'd say, why don't you put a hot pack on? And then I'd arrive to the unit and I'd say, where's the hot pack? And to say, I put it on, but where it is, it's in the bed. So think about that when you put in a hot pack on to keep it in place for that time. You want to probably wrap it in a towel, or you can wrap it in a chuck and, give it time to dilate the veins. It is the cheapest technology. It's available, and it does work sometimes. Then, as this is our phototherapy, and most of you, I'm sure you're familiar with it, as our units have our vein finder or vein viewer. And what it does, it uses infrared light that's picked up by hemoglobin and emitted out. And as you see, create a mapping of the veins. What is good about it is you can see the bifurcation and arches, so you have a clear direction as to how to thread your needle. So it does work often. It doesn't increase the vein diameter, and it doesn't make them palpable. So in the end, it's about the insertus technique in getting superficial veins. Then we have ultrasonography. This ultrasonography is our ultrasound guided IVs. It's the gold standard. What's good about it is it can locate deep veins. It's able to measure the depth and the width, and it can tell us whether or not the veins are occluded with clots or sclerosed. The problem with it is it's underused because it requires provider training, and for some reason it's not fully utilized, but it's available and there for us to use. So these are the benefits and risks, like everything else. So the advantage of having the ultrasound is increased first-time success rate, access to deep veins, reducing the number of sticks, and a lot of patients are satisfied with it. You may notice you have a patient who is a difficult venous access or has a DIVA status, and the first thing the patient is going to tell you, the last time I was here, they used the ultrasound, and you're not going to stick me without the ultrasound. So from the get-go, if you realize that, that should be your red flag that maybe that's the route you should take. Your vein finder, like I said, you can find superficial veins, the bifurcation. It's a shorter time to access than the ultrasound, because the ultrasound requires setting up a sterile field and all of that. Your hot packs dilate the veins and increase the diameter. But the disadvantage is when you use the ultrasound guided IV, if the IV is not long enough, more than half of the catheter is sitting within the tissue and not in the vein. So if the patient moves suddenly, it infiltrates. And because it's in a deep vein, especially if the patient has a larger limb, you will not detect the infiltration. And by the time you actually notice, half your medication or IV is already sitting in the patient's arm. So the disadvantage is infiltration. You can accidentally puncture arteries. Nerves can be damaged. It takes a while for provider training. Our vein finder are unable to detect deep veins or veins greater than 5 millimeters, and it doesn't distinguish veins from arteries. And our hot packs basically potential for burns. So, looking at all of what Julia said, and given the technology we have available, our patients with difficult access often outdo all of that. You could have done your best job. You could have called the vascular access team. You could have called the clinical impact team and the ICU nurse. And if the patient, some of our patients, our sickle cell patients, our liver patients, our renal patients, those chronic illnesses, they will outdo all of the resources we have. So the Michigan Appropriateness Guide for Intravenous Catheter is an evidence-based strategy that was designed by a group of clinicians, multidisciplinary team, physicians, nurses, you name it, got together and came up with this guide. Because in the past, what would happen um, is that patients would come in, they would present as difficult access, and if you couldn't get an IV, straightway you would go to placing a PIC. However, this guideline guide you in finding the most appropriate catheter based on the patient's needs. It reduces complication and addresses overuse of PIC lines and provides a clear practical recommendation. So you may not be able to see this based on where you are, but this is just an algorithm depicting basically patient history. Does this patient have a history of difficult access? Does this patient have one of those chronic diseases? And if so, how long is the therapy needed for? So let's say the patient came in, patient is a sickler, they're in the emergency room, they're in pain, they could not get the IV. What it's saying is this patient should really have an ultrasound guided IV from the get-go. However, if the patient is going to be in the hospital for more than a week, this ultrasound IV should gravitate towards something like a midline. And if the patient is going to be and the midline is good for about 28 days, as we know. The midline can, you can infuse most medication through it. You cannot draw blood from it, so that's one of the downsides of it. However, if the patient needs a vesicant, an irritant, or something like TPN or chemotherapy, then this algorithm guides you as to the type of catheter you should choose. So it's very user-friendly. It's something that we have the potential to design. And I know a lot of you are there waiting for that evidence base, finding that piece of evidence to answer the question or solve a problem. And this might be something you would want to look into. So based for DIVA, which is our difficult access patients, these are the recommendations from the MAGIC guidelines. Establish that status. Use ultrasound guided technique. If the ultrasound guided IV is going to go beyond 6 to 14 days, then transition to a midline or PIC. And when you're using a PIC line, in particularly, you have to be careful of the patient's renal status. Often, when you do a consult with the vascular access team, one of the things they want to know is the patient glomerular filtration rate. If it's 30 and below, they may not want to place a PIC in that patient's arm because a patient with that renal status potentially will need in the future a dialysis, whether it be an AV graft or fistula. And PIC lines has the tendency to cause thrombus or vein sclerosis, and then the patient would lose the ability to use those veins in the future. So given all that we've said, our dear midline is an intermediate access. We did mention the duration. It's short term. It's used for any patient population. In other words, even if the patient has certain problems, they can still receive a midline. You can use it for power injection. So let's say your patient is going to CAT scan CT of the abdomen. You can, and CAT scan is calling, you check if it's a power midline, usually placed by our team, then it can be used. And according to our policy, it's recommended that it's changed every 28 days. The downside is you cannot draw blood from a midline. So often you have a patient who is a difficult access, you have them on a heparin drip or they're receiving a blood transfusion, and you want to draw the CBC every 4 hours or the PTT every 6 hours. And here you now have to stick them. So the patient gets very angry. You said, if I put this line, you don't have to stick me. And yet you have to stick. So be mindful, because in this case, if that patient is a true diva, that patient should have maybe a single lumen pick, because then you would be able to draw the labs, etc., and avoiding extra sticks. Then we have our pick line. Most of you have seen a pick line. Usually it's placed either by our vascular access team or by our interventional radiology team. It's a small catheter inserted in one of the veins in the arm, deep veins in the upper arm. You have the basilic, the cephalic, and the brachial veins. And it's selected using, again, this ultrasound, and it's guided into the superior vena cava right next to the right atrium. And again, it's good for frequent blood draws, and it would be ideal for our patients with chronic conditions. And if we have failed ultrasound guided IVs, then our non-tunnel catheters. These are the ones we typically call, oh, the patient has a central line. These catheters are usually placed in the IJ, in the or in the femoral vein, but they're short-term use. They're placed mainly for patients who probably went to the operating room, needed multiple transfusion, or in an emergent situation. They can be used for hemodynamic monitoring, etc., etc. And these catheters, they're good, but for that immediate short period, but not for long-term use. Then we have our tunnel catheters. I'm sure you've seen the patients on the unit with a chest catheter. We call it a SICK. It's similar to a PIC, but it's tunneled under the skin, and it's threaded in the same fashion and sits in the same, the tip sits in the same position as our PIC line. And the good thing about a tunnel catheter is that patients can go home with it, and patients can have it for a very long time. So let's say we have our patients on 8-monthly or 7-monthly receiving chemotherapy. You would notice they have a tunnel catheter similar to a dialysis catheter. In fact, we confused it for dialysis catheter recently, and we had to make some clarification. So things that you can do, you can go to the inserter's note or the provider's note, and you could see the reason for the insertion if you're not sure what it's there for. All right, so these are tunnel catheters, and our patients who are receiving chemotherapy, who come back and forth, they are the ones who benefit. Also, similarly, our patients on dialysis awaiting AV fistulas, they do have often tunnel catheters in place. And then we have our Metaport. Our Metaport is a type of tunnel catheter, except the access port sits as a small dome under the skin. The problem with the Metaport is that you have to be competent in order to access the Metaport, and it's only limited to some units, like the oncology units and some of our ICUs. And what I find is that providers are very nervous about using it. They're not familiar with it. So the patient comes in with a Metaport. They don't have any veins. And the provider would say, oh, no, I'm not touching that port. That, especially the surgical team, I'm not touching the port. However, you know, if you truly understand the purpose of the port can be used, right? So the next time you have a patient with a Metaport and the provider seems very nervous about the port, you can say to the provider, the port can be used. Prala said the port can be used, but let me call the vascular access team. All right. So this is what you experience. Multiple sticks, patient in pain, or patient being treated for sepsis, urinary tract infection. You cannot give them medication. You cannot treat their pain. The patient is angry, the family is angry, the provider is yelling at you, and you're in distress. This is a common feeling because what? You feel like you failed the patient. What should you do? Should I stick them again? And your back is against the wall. Then you hand over to the day shift. By the way, I missed the medication last night, and the day shift is saying those night nurses, and the night nurse is saying that day nurse, and then the blame is, oh, we call the IB team. The IB team didn't show up. They're busy inserting a pick, or um we call the clinical impact team. They're busy in a rapid response. So it's back and forth, and the stress that you feel is real, and also sometimes it's carried over to the patient. So be very mindful clinical implication of all of what we're saying thus far. 90% or more of our patients will require a peripheral IV. A third of those patients will have their IV failed, especially those patients we consider difficult venous access. So what can you do? Early recognition. So you usually have rounds. I've attended rounds on 4D, and they would say anyone with a Foley, anyone with a central line. But so now maybe you can say, how would anyone who is a diva? Maybe, right? We could bring our divas into our rounds so we can address the plan of care for vascular access. We should, as nurses, we should render care that is patient-centered, using evidence-based strategy to guide us so that we have better outcomes. A great resource is our vascular access team. Excellent nursing, but guess what? This is a limited resource because according to our policy, the bedside nurse is responsible for placement of peripheral IVs. So if you call the vascular access team and that patient is a true diva, they will come and they will assist. But most of the times, they're busy inserting midlines and picks and managing our central venous access devices, changing the dressing, collaborating with providers and access of choice. So be very mindful. What are our solutions? Patient engagement, right? We engage them in multiple aspects of their care. So engaging them in vascular access is also acceptable. Advocate for them, escalate the IV problems, collaborate with other members of the team, the providers, other nurses in order to meet their needs, right? And key takeaways, like we've said consistently, it's about acknowledging that there is a problem, right? Patient said, listen, I'm a difficult stick. No one can get me. Don't see this patient as a challenge or a problem patient. Accept what the patient is saying and bring it to the team and begin addressing the vascular access needs. And what can we do? It's always back to the evidence, right? Collect the data. You can do that as part of your clinical ladder, or if you're in school, collect the data. Analyze the root cause for failed vascular access. Leverage technology. Go back to your infrared technology, use your thermotherapy, and if they fail, refer the patient for an ultrasound-guided IV. Also, how about developing an algorithm similar to the Michigan group so that we can escalate care? This is something we are lacking. There's a need for this, and this is something that we can do. This way, we can increase our first attempt insertion success rate. Make that one stick count. Thank you. We're open for questions. So preferably with the tourniquet off, because you should not leave the tourniquet in place for an extended length of time. So tourniquet off, and then prior to the insertion, you can apply the tourniquet. Well, things that we go right back to the hot pack, right? The hot packs. It's a true secret. The hot packs. People ignore them and abuse them. But if you put the hot pack on, but not just put it on and walk away, wrap it up nicely, and then come back. 5 to 10 minutes, veins are popping. And the tourniquet, one of the issues with the tourniquet is that it's placed loosely. It's not placed tight enough. I mean, you put it on and you can check the pulse, the distal pulse. You don't want to lose the pulse, but it should be tight enough to engage the vein. When working with some of the nurses on the night shift, I was recently teaching them how to insert peripheral IVs. And one of the things you guys remember was that the tourniquet was loose. Everyone had trouble applying the tourniquet. So again, it's about technique. And lowering the arm, lowering the arm. Good lighting, bed height, positioning yourself, aiming. Like, don't go in rough. You're gonna go in like you tread like this. It's about this. It's just the wrist. It's not the hand. Okay? Just this. The algorithm, we would try to locate it, and
If you look up like research like the magic, like you know, how you spell out magic, just model parameter or like here, let me go back. Go back for you. Okay. Yeah, you can, we found this on like a research database, but you can find this online. If you go through the Northwell like library, their resources are available. This is published and it helps like really well. Like it states up here, like, is this emergency access? You can go no, yes. If it's a no situation, you're going to see if it needs hemodynamic monitoring, like TPN, complex infusions, and then you go no or yes. Let's say no. What is the expected duration of access? Short term is under 5 days, and then midterm is over 5 days to 2 weeks, and then you basically just keep going down, and it really helps to give you like a picture in your mind for the plan of care. You know, obviously keep an open mind because things can change based on your individual units, what access you need for your patients. But this is a great resource and tool, and it's a published tool that they did extensive research on. I don't know if providers get an in-service on difficult intravenous access patients. What we're striving for is kind of the use more of like teaching providers who are on the floors who have the abilities and who have the access to ultrasounds and to implement that as a tool because we're fortunate enough that our hospital has these resources. A lot of places when you know, different hospitals don't have that type of technology. Providers can also do their own individual research based on the units and their individual patient populations, which access would benefit their patients the most. If you're on a dialysis unit, if you're in the ICU, if you're on a med-surg unit, that's going to vary based on, you know, patient population, individual risk factors, length of stay, you know, medications that they need. That's all going to, you know, impact what type of access you need for your patients.
and I just want to add that the bulk of the research on difficult vascular access was done by physicians, not nurses. There's some of it was done by nurses, but the bulk of it was done. And who uses the ultrasound? It's either nurses in the ICU or the providers. They're aware, but remember, they're covering, when you think of nurse to provider and the patient population they're covering, they wait for the directives from nursing as to how to proceed. So, and we work as a team, okay? So sometimes you have to work with your providers and guide them.
It's always good to like stay open with your providers, communicate to them, tell them if, the nurse before had difficult getting access, you know your patients the best and can gauge what type of access would benefit that patient the most.
Yes? Thank you, Oki. Hi, Donna.
Again, I think, yeah, I I think like the nurses in the ICUs are fortunate to have like the resources and the education on how to place the lines. And if they're competent and feel confident in placing those lines, it definitely benefits those patients, especially when you're trying to take out the central line and a midline might not be indicated. When the patients go onto the floor, it might be a different story. The nurses need proper education on these types of lines and not mistaking them for something that they're not. Um, it's always important to keep assessing those types of lines because, you know, things can change in the patient. Certain medications can affect the integrity of like an AccuCath or a Power Glide. So that's important to, always keep assessing. I think it's a good alternative if the patient doesn't need a midline. But again, we just need more education on the nurses, like on the floors and also in the ICUs, on like how to take care of these lines and how to place them.
So, as you know, Donna, when you administering chemotherapy through a peripheral IV, it's constantly assessing for blood return. And it all depends on the medication that's being administered. If it's a vesicant, as we know, the IV could be perfect, but for some reason, based on the patient vasculature, it can seep through. So the gold standard usually for oncology patients is central venous access devices.
I would say like our team isn't really a resource anymore for IVs, and I think that's known in the hospital. If we do have time, it's like I'm sure if you've called our team, it's like a very rare occurrence. We'd like to help you more like guide which, IV line or which type of access would benefit that patient the most. I know on nights it can be very difficult because you're limited with resources when it comes to providers and just who you can contact when you need help. So if I was like a, nurse at night and I didn't have good IV access and my patient, let's say, was decompensating, I would right away escalate it to the provider, whoever's there, because you need to maintain patient safety at the end of the line. Um, so I would go from there. If it's something non-emergent, I would see if there's any senior nurse on your unit who can help you. You do have other resources, but I think as a nurse, I would escalate it either to management or to the provider if you are having trouble on nights.
And just to piggyback off this, I know that at nights as an educator, and given the privilege that I've had as being the vascular access nurse, if I'm rounding, nurses have pulled me in the room and I've helped them. So sometimes they can call nursing education. Some of our administrators are excellent with IV placement. So our administrative staff usually assist as well. But it takes us right back here to planning. Okay, so if we really take any takeaway we get from this is about planning. That difficult access should not be 2 o'clock in the morning call. It should be recognized earlier on and with good planning, select an appropriate alternative. So hopefully there's something we can take from this and progress further in, like Michigan Hospital did and other hospitals, unless we want to invest in a bigger IV team, but that's not for me to say. I'm just throwing it there. But then technology, if not, should we train more nurses in using the ultrasound? Should we question? Okay, so that's where we are.
Thank you.
Any other questions, comments? Sure. Can you speak up a little bit? What was the question? And the IB champion. So the IB champion group, it's a different group. It's run by the clinical impact team, groups from the clinical impact team, and it's usually advertised. So keep an eye out for the next group, and it's advertised and you apply. Okay.
Any other questions?
So you could sit.
Okay.
Sit down.
Thank you, everyone. Thank you.
Thank you.
That's back to
You
you.
could end it.
Um,
Yeah.
I think